So today I'm going to talk about why it's important to tell our stories. So tell your story, why telling our stories matters. I believe we all have stories, the ones that we read, the ones that we write, and the ones yet to be told. Today I have the privilege of sharing parts of my story, and Lindsay alluded to a little bit of that today, but then also to discuss why I believe it's my job and my vocation to help facilitate the stories of others. So my story, we'll call it the prequel. The only thing I ever could envision myself doing was being a nurse. My mom is a nurse, and so like every other kid, I wanted to be just like my mom. And I continually barraged her every single day she came home from the hospital for stories. Typically, it was stories of, did she meet any kids that day? What were they like? What was going on? I asked about the gross and the gritty and the dirty, and my dad just stared off into space during dinner time. So I was constantly asking questions about these things. And so when I entered school and I started learning about the sciences and the different things that kind of built the science part of nursing, I was invested in that. I thought I was going to be a pediatric nurse. My colleagues from the department will laugh at that, as they know that that's not what I ended up doing, but we'll get into that as we go along. On the screen, you'll see itty-bitty me at my high school graduation with my parents. I knew that I was going to go to nursing school, and so I worked with that in mind. I was writing my story the way I saw fit and the way that I believed was the direction I was heading. However, my story took a next step when I went to Calvin College. So I started Calvin College. It was Calvin College when I started there, not university. In 2013, I was accepted into the nursing program, and I began to take all the classes that I had been dreaming about and excited to learn the skills and the theory behind what I believed was my calling. I enjoyed my first clinical rotations. I still thought I was going to be a pediatric nurse, and I believed that that was the story I was writing. However, God was starting to write a different story. He was starting to edit things and change things and put in some plot twists that I was not anticipating. The summer before my senior year of nursing school, I began working in an adult foster care setting. At that location, we cared for women who were older adults, but were all diagnosed with some form of cognitive deficit or had some sort of developmental delay. I loved my residents. I fell in love with them and their unique personalities and the things that made them a little goofy, the things that made me love them, and the stories that they shared with me. I began to see them not just as my residents, but as people who had lived a past, who could teach me things about who they were and where they had come from, and the things that made them unique and the things that they believed made me unique. I especially loved that most of them had dementia, and I was learning how to communicate with them even when they didn't know how to communicate with me. And I was learning how to give directions and communicate in a way that would help them achieve the goal that they had in mind or that I may had in mind, even if that was as simple as getting them to the shower. They were teaching me how to tell their story even when they didn't know how to tell their story anymore. Those stories were imprinting on me even if I didn't realize it at the time. I graduated from Calvin in 2017 and began looking for a job as an RN. The story I had been writing in college had already had some drastic changes. I no longer wanted to be a pediatric nurse. My pediatric rotation quickly took that out of me, where I said, this is not for me. I, on the other hand, knew after my undergraduate program that I did want to go to grad school. I didn't know exactly what I wanted to do at the time, but I knew that I was going to pursue more education at some point. I began looking for jobs in med-surg and other locations that would help me grow my skills, gain confidence as a new grad nurse, and I found myself at Blodgett Hospital, part of the Spectrum Health System, now Corewell, and getting a job as a new grad nurse on the acute care of the elderly unit, also called the ACE unit. So as I jumped into this new education of learning on the job, learning how to take theory and skills that I learned in school and put them into practice, I was engaging with the population I had started to fall in love with. I was blessed to fall deeper in love with them and deeper in love with the skills and the people that I worked with every day that also loved this population. I witnessed happy stories of healing and some close calls, but I also was the viewer of indescribable heartache. The most impactful were those who were there with dementia or associated conditions, the ones that could no longer tell their story like they used to. I often had the honor of walking with some of them during their last days, and sometimes they would leave this world like a whisper, very gently. We'd care for them, manage their symptoms, and then they'd say goodbye. Other times, however, I also saw times where patients' loved ones would not let them go, where they would be put through procedure after procedure after procedure with no quality of life or maybe lower quality of life than they had before. And I would face the terrifying thought of if this person stopped breathing or this person's heartbeat stopped, I would be forced to perform CPR on a frail individual who would likely never wake up the same or wake up again. This two ends of a spectrum of what I call a good death and a bad death create a mark on me that would forever change me and change the progression of where I was going. So on the ACE unit, I learned a lot and I grew to love my family that I made there. I went to weddings, I saw babies be born, I made some of my best friends in the world, and that really, really changed who I was. Something that also changed is that I was going to stay a year, get some good med-surg experience, and then I was going to go to the ICU to get critical care experience because I had decided I wanted to be a nurse anesthetist. I was going to go to grad school, be a nurse anesthetist, and you have to have critical care experience or an ED experience to do that. That was my plan. But after a year, I was still there, and then another year, and I was still there, and another year, and I was still there, and I didn't want to leave. I did some shadowing, I investigated what it would look like to be a nurse anesthetist, and I decided that sounded like the most boring thing in the world. To sit behind a curtain, to be separated from my patient, and to not have the teamwork of colleagues of nurses surrounding me at all times. So I felt like I was in a storm, being tossed around, not knowing where I wanted to go, because my whole life I had had a plan, and I was on the plan, and I was sticking to the plan. It changed slightly, but nothing so drastic of not knowing what I was doing next. And I didn't like not knowing what I was doing next. So I began investigating a little bit more, and I decided on a different path. I decided that I loved geriatric population, and that was the path I should stick to. My story, grad school, and a pandemic. So all of my experiences and God's prompting really pushed me to grad school. Like I said, not to become a nurse anesthetist, but to focus on the care of older adults still. And so I began my grad school journey in the fall of 2019 at University of Detroit Mercy. I decided to enroll in the Adult Gerontology Clinical Nurse Specialist Program, which is a big mouthful way of saying to be an expert in caring for older adults and advocating and caring for nurses as well. I wanted to be able to advocate for the nurses that I had worked alongside and built strong friendships and teamwork with for so many years, and I wanted to be able to help patients at the same time. I also had begun precepting both new graduate nurses and students in their leadership or internship rotations, and I loved teaching. I loved showing students what tasks looked like, but I also loved seeing them make connections in critical thinking and clinical judgment. The COVID-19 pandemic hit in March of 2020 in Grand Rapids, and I learned that we were never going to practice nursing the same way again, that things were going to change, and I could do nothing about that, which, again, I didn't like. I was going to grad school, I was working full-time, and I was fighting a pandemic. Definitely not a plot twist that I would have written into my own story, but obviously God has different things in mind for us. You can see me all garbed up taking care of our COVID patients. Despite fighting a global pandemic, I graduated with my Master's of Science in Nursing in the spring of 2022. And 2 weeks later, I started my doctoral program for my Doctor of Nursing practice degree. God, once again, had kind of altered and edited my story a little bit. I was still going to be a CNS working and thinking about geriatrics, but he also told me that you're going to go into academia and you're going to be a professor and you're going to teach the next generation of nurses. I did not know what I was doing. I never do. And so I just said, well, I guess this is where we're going because this is what you've called me to. On the screen, you'll see pictures of me and my family and my best friend, Sarah, at my MSN graduation. My story, Hope College. In the early part of 2023, I was teaching a clinical rotation for the new nursing program at Cornerstone University. I was also working full-time on the ACE unit still, and I was going to grad school. That was my life, hence why I still like to be busy to this day. I know nothing different. I was in my second to last semester of my DNP program, and then I decided this is a good time to apply to a full-time position for a job as nursing faculty at Hope College. I knew God had called me to this next step, to be a professor of nursing. I did not know where, though. I thought maybe Cornerstone University. I was already teaching adjunct there. I was enjoying getting to know the students in their small cohort. I was getting to know the different professors in the program that I liked. But they were so new, they were not hiring yet. So I was impatient. And I said, well, there's a position right now I could apply to. I probably won't get it. And then I'll be at least prepared for the next time I apply somewhere for interviewing, and I'll feel more confident. So I applied. I got an offer for some reason, and I accepted the offer. I started as assistant professor in the nursing department here at Hope in the fall of 2023. I was still finishing my doctoral program at the time, but thankfully through course release, I was given time and space to complete it that semester. I had no idea what I was doing every single day, but I'm really good at hiding things. And my colleagues were wonderful. They were helpful, and they were supportive, and they thought I was smart, even when I thought I was an idiot. I felt completely blessed, and I knew that God had put me here for a specific reason with these specific people. So on the screen, you'll see me at my DNP graduation, part of my DNP cohort on the far side there, and then me with my mom, who was a little bit proud. My story, the sequel, helping others tell their stories. So now that I'm here at Hope, I have the resources and more of a capacity, now that I'm not doing my own homework anymore, to work on the next part of my story. And for me, that's more about helping other people tell their stories and helping our nursing students learn how to facilitate those conversations than it is telling my own story. Earlier, I mentioned how my experiences on the ACE unit colored my view of what a good death is and what a bad death is. My doctoral work focused on ensuring that every person, no matter their cognitive ability, was given the opportunity to tell their story, what was important to them, so that they could express their wishes, their desires, their concerns, their fears, the things that they would not want, the things that they would want. My own grandmother, as Lindsay mentioned in my introduction, had dementia, and she began her decline when I began practicing as a professional nurse, and she passed away in 2020. My grandfather was her full-time caregiver, just lavishing her with love every single day. I have never seen somebody with more pristine skin at end of life than my grandmother because of the care that he took with her. This example of love in action, in acts of service, in unconditional service, were what pushed me to really express this love to other people in a way that helped them express their love in a way that was recorded and preserved so that others could follow it. So I decided that I needed to help other caregivers, other people like my grandfather, invest time and knowledge in being able to follow the things that were important to their loved one. Which led me to my study of implementation of a dementia-specific advanced care planning tool. And the literature is pretty clear that there's a lot of issues when it comes to advanced care planning, specifically surrounding those with dementia and other cognitive deficits. One of the big things is that many individuals with dementia don't understand the terminality of their diagnosis. They don't really understand what dementia is, and that they will have it to the very end of their life. They don't understand that there's no treatment. that will fix their problem, that some of the things we have right now merely will maybe, potentially, delay their symptoms and delay progression, but there's no guarantee. And there's also minimal good education for them that will describe how varied their experiences will be. Also, a lot of people don't want to talk about the end of life. Our culture in the United States has really put a hush on discussing death and discussing what's important to people at end of life. And so a lot of people say, well, my daughter will know what to do when the time comes. My husband will know what to do when the time comes. And so they push it back and they decide, we're not going to talk about this because I won't be there to make those decisions anyways, and that'll be okay. Secondly, we learned that surrogate decision makers don't know what their loved one would want. There's the pressure of making decisions when they don't know what those decisions should be. And because they've had no preparation, they've had no discussion, they've had no documentation, they're faced with immense burden and guilt and long lifetime suffering sometimes because they are faced with the thought of, did I make the decision that my mom would have wanted? Did I make the decision that my dad would have wanted? And if not, what does that mean? We also learned that individuals with advanced care planning, especially those with dementia, have better quality of life at end of life when they've had advanced care planning discussions. These include lower rates of interventions that often are unwanted at end of life, including going to the emergency department and going to the hospital in general. They also face lower levels of invasive procedures, such as having tube feedings inserted or being on a ventilator. And then finally, we learned that primary care providers, nurse practitioners, clinical nurse specialists, anyone in the health professionals, they tend to feel underprepared and ill-equipped to have these conversations with anybody, especially those facing a cognitive decline and not knowing how to bring those conversations up. All of this led to the understanding that there is minimal dementia-specific advanced care planning guidance and tools out there, and that the advanced care planning that is available does not talk about things that are really important to talk about with those facing cognitive decline in their future. So the purpose of my study, I won't read this whole thing, was basically to implement a dementia-specific advanced care planning tool among individuals diagnosed with a cognitive deficit and determine, does this tool help increase knowledge of dementia, the progression of that disease, its terminality, and end-of-life decisions that come along with that, and also to increase the surrogate decision maker confidence that they know what decisions their loved one would want. And all of this overall, the hope was to decrease healthcare utilization rates, including emergency department visits and inpatient stays, so that we were not having our patients undergoing those treatments that they did not ever want. So my doctoral study was at a program called Care Resources PACE in Grand Rapids, Michigan. This is part of the PACE system, which is a national system throughout the US. And their program is called PACE because it's Program for All-Inclusive Care for the Elderly. And they work on providing all-inclusive care for individuals 55 years or older who qualify for a higher level of care that could be done in a nursing home setting, but because of this program, most individuals are able to stay in their homes or at a lower level of care, such as independent living. They provide lots of things. They are their PCP, they're their insurance, they provide PT, OT, speech pathology, durable medical equipment, prescriptions, transportation, et cetera, et cetera, et cetera. The beauty of this program is that it's covered by Medicare and Medicaid, and so people are part of this program and they don't have to worry about paying for things individually. The program helps them cover all of that. What I really loved about this program is that the people that work there know their participants. They know their names, they know their children's names, they know the things they like, they know the things they don't like. It felt a lot like being at the adult foster care again, where the people that I was taking care of every day, I was getting to know and love on a personal level. The people that work at PACE, at Care Resources specifically, they know their participants and they know them very, very well. So I got to love and care for some of them very deeply, and I began planning the study at this setting. They had an advanced care planning tool that they were using, but the process that they used it was inconsistent, and it was not addressing a lot of these things that we talked about with specifics needing attention with dementia care, that was not covered at all. And most of their patients, their participants, had a cognitive deficit either when they enter the program or they develop one later on as well. So we decided to do a quality improvement pilot where we took the standard advanced care planning tool and replaced it with this dementia-specific tool called the Dementia Directive. And we did this with new enrollees who had a cognitive deficit diagnosis, dementia or a mild cognitive deficit, or when assessed using the Montreal Cognitive Assessment, or MoCA, they had a score of 19 or less that put them in one of those categories. So we met with those individuals, the primary care providers and the social work team collaborated with me to identify new enrollees who met these criteria. And the other criteria was that they had to speak English, because that's all I speak. And they also had to have someone in their life that could be or would be their surrogate decision maker in the future. So this could be a daughter, a son, a spouse, a friend. It didn't matter who it was, but they had to have somebody that would meet with them and be that decision maker for this project, and potentially would be activated in the future to become that decision maker in the event it was necessary. So instead of this standard tool that they use that the state of Michigan publishes, we use the Dementia Directive, and I'm going to talk more about that on the next slide. So on the far side here, we have a slide or a piece of the Dementia Directive, and this directive is really cool because it, in the beginning, offers education about what is dementia, how does it progress, what are signs and symptoms, and it is very, very clear that there is no cure and that treatments only may delay progression but will not fix the problem of the disease itself. So what we did is we met with our dyads, as we called them, one individual with dementia or cognitive deficit and their surrogate decision maker, and we first assessed their knowledge of how much do they know about dementia, about its progression, end-of-life care options. What did they know about this already? We did that for both our participant with dementia and our individual who would be the surrogate decision maker. And then we also assessed the surrogate decision maker's confidence level on how well do they know their loved one's wants and desires currently, before any discussion had been had. We then introduced this tool, and this tool, like I said, offers education at the beginning, but then it walks through 3 stages of dementia: mild, moderate, and severe, and it provides a good description of common signs and symptoms or experiences that people might have in each of those stages. This was really helpful so that we could explain a concept or a word to somebody, but then also let them discuss what that might look like. A lot of the people we talked to were in their mild stages already, so they could relate to what they were describing because they were experiencing it currently. It then asks what kind of care you would want at each of those levels. A do-everything approach, which we would call full code. So no matter what happens, I want CPR, I want to be intubated, etc. A DNR with aggressive treatment approach, which is do everything you possibly can until my heart stops beating or I stop breathing. I would not want CPR. I would not want to be intubated on a ventilator. Or the comfort care approach is where I am not trying to fix problems anymore. I just want to be comfortable and to manage my symptoms, but I don't want to go to the hospital. I don't want CPR. I don't want to be on a ventilator. I just want to be comfortable and with my family. So at each stage, our participants with dementia were asked which of those things met their wishes the best. And so we were able to walk through each of those stages as it progressed through the disease and decide and help them discuss with their surrogate decision maker what things were important to them at that point. I then developed also this supplement tool that you'll see on this side that specifically asked about interventions that are common in older adults and those particularly with dementia, and asked our participants if they would or would not want that. A great example of this is a feeding tube insertion, because people with dementia often lose the ability to swallow, talk, or eat long before death, and sometimes we insert a feeding tube and sometimes we don't. And it's important to know somebody's preference on this before that comes to that point when they can actually communicate those needs. So these are our instruments that we used for our data collection. On this side is our knowledge assessment, and on the other side you'll see our confidence score using a Likert scale that we asked our surrogate decision makers. After we met with them and discussed our ACP session, went through the paperwork, recorded that with the social worker and myself present. We then asked these things again. We wanted to see, was there an increase or a change in their knowledge for both participants in the dyad? And then we wanted to see if the confidence of the surrogate decision maker changed at all as well. 3 months later, I followed up with the dyads again and asked them the same things. We did the knowledge assessment again, and then we also did the confidence assessment again to see had anything changed in the course of 3 months since the time that we had our advanced care planning session. Our results were that we had 10 dyads complete the pre-implementation survey, our advanced care planning session, and the immediate post-implementation surveys. 3 months later, I was able to get a hold of all 10 of our participants with cognitive deficits and 9 of our surrogate decision makers. 1 we could not get a hold of. So we had those complete our 3-month follow-up. Some demographic things that were interesting. We had about half of our individuals with cognitive deficits were African American and the other half were white. All of our participants with dementia or cognitive deficits were female. We could not recruit any that were male. Either they did not speak English, they were not newly enrolled to the program, or they did not have somebody that would be their surrogate decision maker, or they didn't want to participate. About half of our individuals with cognitive deficits were in their 70 to 79-year-old age bracket. We did have one that was like 94. And 8 of our 10 surrogate decision makers were children of the individual with cognitive deficits, so a lot of children involved. As you recall from the purpose of my study, we also wanted to investigate if doing this advanced care planning would help decrease healthcare utilization rates. And so I did a chart review where we looked at the combined emergency department and inpatient rate of admissions for our pilot participants. So manually going in and seeing, did they go to the emergency department? Did they have an inpatient stay? We did this for our pre-implementation, and we saw that combined total was 10 visits. And after the advanced care planning sessions, we found that we had a total of 5. Because Medicare and Medicaid funds all of the PACE program participants' needs, they try to stay in their system as much as possible because it saves money. So they try to stay and use their triage system, use their chain of care in order to help save money and avoid potentially ED visits and inpatient stays that maybe weren't necessary. So if somebody is having some sort of symptom at home, they're asked to call the triage nurse, and the triage nurse either makes a follow-up appointment with their team at PACE, or if it's life-threatening, they say go to the emergency department and they can take care of it from there. So by avoiding 5 potential ED visits or inpatient stays, we help save, or suggested that we may have helped save cost savings of $10,000 to $15,000 in just about 4 months. What our research findings showed were several different things. First, individuals with dementia and their surrogate decision makers do not understand the terminality of the disease. So this did confirm what the literature had told us. And we saw in our knowledge scores that the pre-knowledge scores were much lower than our immediate post-knowledge scores. We also saw that the introduction of a dementia-specific advanced care planning tool helped facilitate these conversations. So they were able to have conversations about things they'd never talked about. It was very common to hear people say, well, Mom, I didn't know that about you, or I didn't know that that would be important to you, because they were having these conversations. We also found that our surrogate decision makers often did not know what their loved one would want. We had a couple that were like, yep, I know exactly what they would want. And even then, during the conversation, they might be surprised by some of the things they learned. But we also found that after our advanced care planning session, their confidence level was much, much higher. And we found that advanced care planning, dementia-specific advanced care planning, could help decrease unwanted medical intervention. What was interesting is that our individuals with dementia, they had no statistically significant results, which we were not surprised. But what was interesting is that at our 3-month follow-up, the score was almost identical to the ones immediately post our advanced care planning session, which was interesting because we would think that people undergoing cognitive decline would have cognitive decline over the course of 3 months and that we would expect maybe a lower score, but it was consistent. Our surrogate decision makers had a statistically significant outcome for both knowledge and confidence, not only right after the study of our advanced care planning session, the immediate results, but at 3 months it was consistent as well. So their knowledge and confidence level stayed consistent despite time passing. So some implications for myself and generally for the future, that we need some more diversity, obviously, in our advanced care planning for those with cognitive deficits. We had a very small representative sample, so we can't really generalize that. But the pilot did suggest that this was helpful and applicable, so we need to see who else we can meet with. For loved ones, we need to identify our loved ones' needs for actually adhering to these decisions. So just because it's recorded doesn't mean that somebody's actually going to follow that. So identifying what is stopping people, or maybe what would help facilitate them to actually adhering to their loved ones' decisions. And obviously getting some diverse backgrounds for those who would be decision makers and understanding that from a variety of perspectives. And then finally, for healthcare providers, to identify barriers to them actually implementing advanced care planning in educational gaps that might exist for them, especially for advanced practice nurses who typically are going to be in a setting where they would be doing this more than a bedside nurse. So telling stories in the Christian context. Where does the story go from here? Well, being here at Hope means that I can continue my work with older adults, which I love. But it also means that I get to be more than just a nurse working with older adults. I get to be more than just a professor working with nursing students, and I get to be more than just a Christian. I get to be all three of those in one place, which I think is beautiful. And I am being equipped to perform research that not only is impactful to people around the world and in my community, but also impactful to our future nurses who are going to be going out and being the hands and feet of Jesus, and being the ones that are helping others facilitate these conversations, having hard conversations with people at the bedside, seeing things that hurt and don't make sense and making sense of them to themselves. So I am very blessed to be able to share my story, help our future nurses tell their stories, and be able to help others tell their stories to make an impact on their lives.
Awesome. We'll run the mic around. If you have, what questions do you have? I'll start us. How about that? Stephanie, could you talk about the experience of having some of these conversations, the advanced care planning with these families, and kind of what that's like on that side?
So I obviously only had a small group of them, but I had some that really kind of enjoyed the opportunity to talk about these things in a way that they didn't have to bring it up. So they weren't the ones saying, Mom, we really have to talk about it. And then I had the ones that they started very kind of icy. And then as they kind of were facilitated and kind of led through, they melted a little bit. I can remember one specifically, sometimes we met in these people's homes, which was very interesting being in their context, bringing something to them that might not be what they wanted to do that day. But sitting on their couch and just answering questions of, what is a feeding tube? What is a ventilator? So that they could have those conversations between the two of them and make decisions that really were what they would want. So clarifying things and putting them in terms that made sense to them and meeting them where they were was really impactful. And having people say, thank you so much for having this conversation with me, because I never would have been able to do this by myself.
Okay, so this is obviously not an area that I'm super familiar with, but I'm wondering how would you deal with a situation where a decision is made and then down the line, like use the feeding tube example. And I know that people with dementia sometimes change their minds or don't know, like what if they had decided they wanted that and then they're being really combative and change their mind? How does that work?
I think that's a good question. I think that there's no easy answer to that. But I think that people tell you through their actions what they want and don't want. And I think that that's one of those areas that advanced care planning is helpful. but it is not the end all be all, that things can change and things do change. And I think that's where, if the surrogate decision maker has been empowered previously to be able to look at their loved one and understand what's important to them, and then see that maybe that thing that's important or was important 10 years ago, however long ago it was that they actually documented that, to know that maybe it's okay to make a decision that's slightly different, because I know at the heart of what's going on and the decisions that they would want to be made, that they would want to be comfortable. And that was the ultimate goal, is that maybe they made the decision about a feeding tube because they're like, well, I don't want to feel like I'm hungry as I'm, still living my life and doing the things I want to do. If that's the only thing holding me up, I don't want that to be the thing that I pass away from, when maybe everything else is going okay. But maybe that changes where now everything's not going okay, and they're not able to do the things they once loved. They're not able to have the conversations they once had, and perhaps it's time to make a different decision.
Thank you very much for the presentation. I am very anxious. What's your recommendation? Because you are a specialist in the area. I see a lot of people doing care work, and particularly taking care of those with dementia. There are a lot of videos that can be circulating on the social media. I was shocked when you say you love the work, because for most of the colleagues I know from home, you'd find that delving into the field, because it's a good paying job and so forth. What's your recommendation on whether these people with dementia are better taken care of at home or in these organizations? I ask because I was trying to figure out what I see people taking care of their loved ones with dementia at home, and what happens in these public organizations where people get employed to take care of them.
That's a great question. I think, again, it's going to be very dependent on the person. So some people have great caregivers. Like my grandfather was a great example of a caregiver that wanted to do this. He said, I signed up for marriage, and that means till the end of my life, and I'm going to take care of my wife for that time. And then there are some people that don't have that support at home. They don't have people to be their caregivers. So programs such as PACE or advanced assisting livings and other places like memory care, that's a great place for them, where they don't have the people to support them. Then there's the in-between, where they have people, but maybe they're not the best people, or those people don't have the capacity to care for their loved ones, or the willingness also exists, obviously. So I think it's really case-by-case dependent. In terms of resources for them, yes, there are resources out there. We know that caregiver burden is huge, and that providing support for them is a big part of dementia care. There's a lot of support groups. The Alzheimer's Association does a really good job of providing virtual tools, like those videos you were talking about, but also providing in-person support groups that caregivers can go, helping them find respite care for when they do need some time to take care of themselves or take care of their children. And so there are a lot of tools out there. It's hard for the public, I think, to be able to flesh out what are good tools and what are not good tools. So definitely an area for experts like nurses to be able to speak to that and to say, this is a great community resource, I recommend them, and then providing them with the tools to get to that community resource.
Stephanie, could you tell us maybe what's one next question that you're excited about as you think about this work? There's clearly so many directions and places it could go.
I think the next part is seeing, do our nursing students feel comfortable providing this care? So we know that the dementia population and older adult population is going to be booming as the baby boomers get older, and as we just have a large group of people entering that age group. So we also know that we need more nurses, that we have a big nursing shortage. So we need to empower the nurses that we do have to be able to take care of this huge influx of people that are going to be coming in with high rates of dementia or cognitive deficits. So my next big thing is, do they know how to take care of these groups, but also how do they feel about caring for people at end of life and competency surrounding that?
A question and a comment. So my aging parents moved near me a little while ago, which is wonderful. So they don't have dementia, but are there tools like this to help me have that conversation with my mom and dad, apart from dementia? But I just can see that that would be really helpful. Also, there's a psalm I love, and maybe people know it. It's Psalm 90, and there's a prayer in the middle that says, Lord, help me to number my days that I may apply my heart to wisdom. And I think about that as the medical field. I think you're exactly accurate, is usually pushing against death, right? That's your role and your job. But there is something to remember, that our days are numbered and they come to an end. And so how is it? I feel like this is what you're doing. You are helping people apply their hearts to wisdom as we look at our numbered days. So thank you.
Yeah, there's a lot of advanced care planning tools out there. There's one called My 5 Wishes, I believe. There's a lot of tools on the NIH, National Institute of Health. They have tons of tools on there that you can use. Some are going to be more clinical, and some are better at like just having a conversation. I think My 5 Wishes is the one that a lot of people use. That they talk about 5 big things, and it's an easy more of an easy conversation to have with like people's loved ones. So that's a great place to go for help. There's a lot of stuff out there if you Google it, but NIH has done a really good job of putting together a lot of things in one place.